This is Chemical Abortion in 2021. My name is Christa Brown, and I am the Director of Medical Impact for Heartbeat International. So why do women choose chemical abortion? Of course, we live in a fast-paced society. Everything we could possibly want is in the palm of our hands. So chemical abortion sort of fits in this model where we can access websites, we can access apps, and get what we need. When a crisis pregnancy occurs and a woman really does not want to be pregnant, the answer can be as simple as going to her phone. She's promised convenience, she's promised privacy, she's promised abortion on demand. According to Planned Parenthood, women choose chemical abortion because they are promised a more natural way to terminate. There are websites that say that it induces your period. And so scientifically that is inaccurate, but yet they advertise that. And if you can imagine the mindset of a woman who so badly does not want this to be a pregnancy that continues, the only thing she wants is for this to go away. And so the idea of a magic pill, the idea of making this part of her past very quickly is very appealing to many women. It's done in the earliest stages of pregnancy, according to Planned Parenthood, and that is true. It's done in the privacy of their own home. And so that can seem very positive for women because they don't have to be in a clinic setting for those that are afraid of needles and the pain of a surgical abortion. But it can be extremely scary and alarming when you are experiencing abortion in the privacy of your own home. Most of the women who call the APR hotline are alone. Very few have anyone with them. And to experience these symptoms, to induce this abortion all by yourself, and then to wonder how much bleeding is too much bleeding, how much pain is too much pain, am I okay, to see their babies after the abortion can be extremely alarming for them. So chemical abortion is different than Plan B, one step, or morning after pill. In the case of Plan B and one step, the intention of that drug is to stop a pregnancy from occurring. But the action of mifepristone, misoprostol combination, the chemicals used most commonly to induce a chemical abortion, these women already know that they're pregnant. They've had a positive test. Most of them have already had an ultrasound to confirm dates. So we have two different scenarios happening here. With a chemical abortion, the woman already knows she's pregnant and she wishes to end the life of that child. So chemical abortion is a non-surgical abortion. It's also called abortion pill or RU46. Really, it should be called abortion pills because there are two different pills taken at two different times with two different actions. It's also called medication abortion. We tend to use the term chemical abortion, and that's because the words medical or medicine imply some kind of healing is going to take place. And really, the only intention of these drugs is to end the life of that preborn child. So there are two different medicines typically given throughout the world to end the pregnancy. There are some others used, but these are the most common. The first is mifepristone, and the second is misoprostol. Like I said, two different drugs, two different actions taken at separate times. The first is called mifepristone, and the action of that mifepristone is to block the body's own progesterone and what happens with that is that the pregnancy stops growing. So progesterone is an absolutely essential hormone in every pregnancy. And so when we block that progesterone, the pregnancy is unable to continue. We've destabilized that pregnancy. We've taken that progesterone to unsafe levels in pregnancy, and it attacks the pregnancy. It does not attack the baby, it attacks the pregnancy. It makes it very hard for the mom's body to continue that pregnancy. So mifepristone is approved by the FDA in the United States up to 10 weeks in pregnancy. Does that mean it's only given up to 10 weeks in pregnancy? Absolutely not. So you can go to websites of abortion facilities and often see that it's given through 11 weeks, sometimes 12 weeks, sometimes 13 weeks. In other countries, it's given much beyond that. So we know that that is the future for the United States, is that we're going to see this expanded. We know that studies are being done in other countries, and not only studies, but it's actually given in commonly in medicine in some of these countries, using chemical abortion to end the life of these babies much beyond that 10-week limit. It's a deliberate attempt to abort a known pregnancy, and it blocks progesterone. So how mifepristone works is absolutely not disputed. Everyone knows that that is the action, that it blocks the progesterone. The development of the embryo is dependent on that progesterone. A synthetic anti-progesterone steroid that works by blocking progesterone receptors. So there are progesterone receptors in the ovary, in the womb, in the placenta, and they're supposed to be filled with progesterone. But this mifepristone goes in like an imposter. It's not supposed to be there, and it inserts itself, and it blocks that progesterone from going into those receptor sites. And so by doing this, it lowers progesterone to unsafe levels. It destabilizes that pregnancy, and it competes with those natural progesterone produced in the woman's body. So progesterone in a pregnancy, like I said, is absolutely essential. It's essential in any mammal's pregnancy. And what it does is it prepares the endometrium, which is that lining of the uterus. It thickens it so the baby can implant and thrive. It develops the placenta so that the baby can get the absolute nutrients and oxygen that baby needs. It inhibits contractions. It keeps the uterus really soft and relaxed so that no contractions happen. And it keeps the cervix, the mouth of the uterus, tight and closed, which is the way it's supposed to be until it's time for the baby to come out. So you can imagine if progesterone suddenly drops in a pregnancy. The body no longer even thinks it's pregnant because the body knows that progesterone levels should be very high in early pregnancy. So what will happen is that endometrium, that lining of the uterus, will not thicken, so baby can't implant and thrive. The placenta may not develop well, which means baby can't get nutrients and oxygen the baby needs, and contractions may start to happen. The uterus may start to get crampy, and that cervix can start to open, which opens up the idea that mom can start to have an early pregnancy loss. It also opens up mom to the risk of infection. So both the mifepristone molecule and the progesterone molecule will bind and release at a particular site. So you can imagine like a key into a lock. That's sort of what it looks like. Mifepristone or progesterone can go into that lock. When the progesterone goes into that lock, it turns the lock, it opens it, it makes progesterone abundant in the body during the early parts of pregnancy. But when the mifepristone goes in, like I said, it's an imposter. It goes in, it does not turn the lock. So it fits in that lock, but it doesn't turn the lock. Mifepristone molecule binds more tightly to the receptor, thereby blocking that progesterone. If the woman only takes the mifepristone and she does nothing else, she doesn't take the second drug, 20 to 40% of the time, the uterus won't empty. And so that is what they realized very early as they were developing chemical abortion. They needed two drugs. The first drug destabilizes that pregnancy by lowering progesterone levels, but misoprostol is needed. The misoprostol causes the uterus to empty, causes those tight contractions to happen where the uterus will empty. The embryo survival after mifepristone, however, is as low as 5 to 7%. So on day one, mom is given that mifepristone, 200 to 600 milligrams, usually orally. Typically, they're given this at the abortion facility, but as we will discuss in just a minute, there are many other ways to obtain chemical abortion. And then somewhere between 6 to 72 hours later, misoprostol is taken. And usually she's told to put this in her cheek and let it dissolve. And that's because the other symptoms that it can create that misoprostol can create some gastrointestinal problems, some other pretty harsh symptoms, can make mom especially miserable as she's having this heavy bleeding and this other pain during her abortion. So they found that giving it to her to dissolve in her cheek is a better way to do that. So then after she takes the misoprostol, then the pregnancy is passed within 2 to 24 hours. And then she is supposed to return to the provider to determine if fetal demise actually happened and if the uterus actually emptied. But for any of us who have worked with women in this capacity, we know that it is not uncommon for women to skip that appointment and not be checked after. So when a woman starts a chemical abortion, she is going to have cramping and vaginal bleeding. There's just absolutely no doubt about it. That's what these medications were intended to do. But everyone is different. And so the amount of pain and bleeding is different for everyone. But I can tell you from experience that many women are shocked by the amount of pain and bleeding that they have. They've been promised sort of this very simple experience. It will come on like a period. They feel like they can maybe go about their normal day, and instead they are in their bedroom and bathroom for the course of a day or two with extreme bleeding and pain. And then the side effects of the treatment can be nausea, weakness, fever, chills, vomiting, headache, diarrhea, dizziness. So it overall can be an extremely miserable experience. If the symptoms like these continue for beyond 24 hours, that could indicate an infection. And so when this is being managed at home, the woman is often alone. This can be problematic. And that's because having fever and chills during the early parts of the abortion is considered normal. Having bleeding is considered normal. Pain is normal. Dizziness is normal during the early parts of the chemical abortion. But if it continues, now it's a problem. So that's what the women are being told. And there's no medical management of this. So she's left alone to decide, do I seek help or do I not seek help? Is this a problem or is this just normal? And it's very hard for many women to determine at what point do I break this. I go get help. They've been promised privacy, so they don't want to tell anyone. They're going to have to call 911, or they're going to have to tell a friend or a family member what they've done. And this is not something that they want to do. They don't want to go to the ER and say, I'm in the middle of an abortion. I think I have an infection, or I'm in the middle of an abortion and I think I might be bleeding too heavy, but I don't know how much bleeding is supposed to happen. So this can be extremely problematic for many women as they are completing their chemical abortions on their own. So when women take both of the medications, the mifepristone and the misoprostol, it's extremely effective. It's at least 95% effective during that first 49 days of pregnancy. And like I said, it is being used more commonly in second trimester. It's less effective the farther along the mom is. In other countries where it's being used well into second trimester, sometimes they will use the first medication and then they will use feticide in the middle, and then they will complete the abortion with misoprostol. So right now, we believe chemical abortion is about 45% of all abortions in the United States. Every state is a little bit different, and so that's an average. There are some states it's as high as 70%, some states it's as low as 30%, but about 45% of all abortions right now are chemical. So we're approaching the 50-50 mark, where half are surgical and half are chemical. This was a chart we made before the pandemic. So this is what we predicted for chemical abortion in the United States. We saw it quickly rising. We expected in 2020 for it definitely to be 46%, going to 50% this year. And then we thought 2023, it's going to be over 50%. And we know that that will be actually much higher. And that's because so many want a no-touch abortion. They don't want to be in a clinic. They don't want to have that one-on-one. The idea that they could do this possibly through telehealth or order on the internet to them is very appealing. So we know that that number that we see for 2023, which of course was just a prediction, we know that number probably will be much higher. So there is a new strategy by abortion advocates, which many of you may have already recognized. In the past, it's always been safe, legal, and rare. And now they are more in favor of immediate access and convenience. So access and convenience seems to be the number one priority. And if anything interferes with that, they believe that something is wrong and something needs to be done. Everyone in the world needs immediate access to abortion, and they need it to be very convenient to them. That seems to be the new strategy of abortion advocates. So while we know that physical examination and ultrasound are standard of care when evaluating a woman seeking an abortion, and counseling can best be done in person, they still are promoting telemedicine for abortion. And they really want those that are away from a clinic to have access to this. But also, if it inconveniences them in any way, they feel like telemedicine abortion should be available to them. And on the left, you see an advertisement for a way to purchase chemical abortion online. So we hear words like self-managed. And I think that feels in the beginning when women are looking for an abortion almost empowering to them because I'm going to manage this. This is not going to be done to me. But you can imagine the implications afterwards when they are the ones that manage this from beginning to end. So less medical supervision. They talk about that it induces a miscarriage, which is not actually medically accurate. Women are encouraged to manage the process themselves. They are promised that privacy, like we talked about, and many are unsure what to expect or when something is wrong. So this is sort of what self-managed might look like, a woman alone in her bathtub, in her dorm room, in her bedroom. And so while they may use words that seem empowering in the beginning, really this is what it sort of comes down to, is a woman typically alone, typically afraid, typically not expecting these harsh symptoms, not knowing she may see her child. So not all women see their child during a chemical abortion, but for those that do, they're often very surprised and sometimes angry that they weren't warned that that was going to happen. They often don't know what to do with the baby. Some bury the baby, some flush the baby, and some keep the baby for a time trying to decide what to do with those fetal remains. Abortion with mifepristone and misoprostol has 4 times the risk of complications as compared with surgical abortion. And I would venture to say that the vast majority of women seeking this type of abortion have no idea that that's true. And that's because the way it's marketed to them. It's marketed as a Tylenol, as an aspirin. It's a magic pill that makes this go away. It's not a big deal. It's something you can do, get past, and this is not the reality. 4 times the complications, and we already know that surgical abortion is not safe for women. So while we mourn the loss of human life with abortion with these preborn babies, we also need to be very concerned about the risks given to these women who are medically dependent on these providers to give them sound advice, and they're not being warned how dangerous this possibly can be. This is something I always like to mention because when I worked in pregnancy help, often people would ask about the cost, assuming that it's just a pill and you barely see a doctor. So, of course, it's going to be much less expensive, right? Wrong. It is about the same cost as a surgical abortion, in some cases more. And that is a bit confusing to many. It definitely is more profitable to the abortion provider because there is no surgical suite, there's no sterilization of instruments, much less staff is involved. I know sometimes the initial medication is dispensed by a nurse, not even the physician. So the idea that it costs about the same is sometimes very confusing, but it's a good thing to know if people are discussing it, that this is not a money saver. This is not cost effective. If you're looking at the difference between a surgical abortion and a chemical abortion, the cost is roughly the same. So in the US, it's usually between $400 and $800. And then but for those that buy it online, now keep in mind that they don't know what they're getting. They don't know the exact chemical component of what they're getting. They don't know the dosage necessarily of what they're getting, no matter what's on the label, because it was often manufactured in a different country and shipped to them. But it can vary in price somewhere between $167 up to $537. So mifepristone was originally developed by a French company, Rousseau-Uclaf, in 1980. And that is the same company that created the Zyklon B pellets that were used to power the gas chambers during the Holocaust. So I just always like to mention this. It may seem irrelevant because, again, it's just a chemical that's used, but the idea that it is possibly same much of the same ideas go into this, where we're eliminating life that maybe is less valuable to some, could be possibly some of the same demons. So like I said, it was developed way back in 1980. And then you can see different countries approved it. Moving forward, the US approved these drugs back in the year 2000. So it's been available in the US for 21 years now. And then you can see other countries slowly approved it also. So the risk evaluation mitigation strategy exists in the United States. Other countries do have similar approaches, but this is the one for the United States. And this is a drug safety program used by the FDA, and it is used only for drugs that have serious safety concerns. And so mifepristone, RU46, is one of those very few drugs that has a REMS restriction on it. But this varies country to country. And this is something that abortion advocates are trying so hard to remove from mifepristone, because if they can remove it, it can be prescribed anywhere. It can be prescribed through Walgreens, CVS, through any commercial pharmacy. It can be prescribed through doctors' offices. Right now, it cannot. It has to be a REMS approved provider that gives it. And so right now, that really does put some limitations on it. And it also tries to keep women much more safe. If it is removed, definitely it will be even more widely used in the United States. This was a bit of a difference between the year 2000, when mifepristone was first approved, when there were some changes in 2016. So if you've been doing this for a while, you may remember that how things used to be described with chemical abortion are a little bit different now. So it used to be there were 3 visits to the clinic: the first drug, the second drug, the follow-up appointment, and now there are at most 2 visits. The mifepristone is taken usually at the clinic when the abortion starts at a clinic, and then the second drug's given at home by herself. She gives it to herself, and then if she wants to, she returns for that follow-up visit that we said some women do avoid attending. So originally in 2000, it was only available up to 49 days of pregnancy. And in 2016, that changed to 70 days. And like I said, that's FDA approval. It doesn't mean when providers will actually give it. The dose actually decreased. It went down from 600 down to 200 milligrams. They found it not to be any more effective at 600 milligrams. The misoprostol dose increased, and the misoprostol is that second drug that empties the uterus. The route of administration, like I said before, is switched from oral to buccal, and that's because of those gastrointestinal, those pretty harsh symptoms that come along from digesting that drug orally. The timing of administration, they went from 48 hours. In 2016, though, they switched it to 24 to 48 hours when you would take that second drug. we hear it all over the place, anywhere from an hour, 7 hours, 24 hours, 48 hours. The one thing that is consistent with abortion providers is their inconsistency. They all do things the way that they would choose to do them. And so we hear all different stories of when they're taking that second drug. And then the follow-up visit after used to be 14 days, and now it's 7 to 14 days. So what they did effectively by increasing that availability from 49 days up till 70 days was they increased the availability of chemical abortion to 37% of pregnancies, up to 75% of pregnancies who are seeking abortion. And so you can imagine, as they bumped it up to 11, 12, 13 weeks during the time of the pandemic, you could imagine how many more pregnancies are now affected by chemical abortion. So it is available online. Many people say, why doesn't the FDA do something about this? And the FDA is a bit helpless to do anything about websites who originate overseas. So many of these websites are foreign, and there's probably only so much they can do. There are at least 72 unique websites, about 30 abortion websites, and 42 pharmacy websites that distribute chemical abortion online. They use advertising that is a bit deceitful. They describe it as pain-free, but then they also list the side effect of pain. They say 100% working, which, as you know, there is no drug that's 100% working. Completely safe, effective, pain-free, and infection-free. Harmless and successful early-stage pregnancy execution. And this is just another ad someone who's selling abortion meds online. So one of the most scary parts about this is that you don't necessarily have to be a pregnant woman to buy this. So when you go to a clinic, there's some sort of evaluation to determine the gestation of the pregnancy, usually an ultrasound. There's a pregnancy test and an ultrasound. In these cases, they are just taking your word for it. So you could be a human trafficker, you could be a boyfriend, you could be a mom, you could be anyone. And we've heard of boyfriends buying hundreds of packs of these. And so we know that this is being used sometimes without a woman's knowledge even. More ads just to show you what they look like. And then there's Aid Access and Women on the Web. Aid Access is the US-focused spin-off of Women on the Web, and these are organizations created to push chemical abortion on nations where it is prohibited by law or they feel it's not easily accessible. And they completely disregard the FDA. They blatantly disregard the FDA. And so while they say that their focus is on areas where abortion is not accessible, we know that not to be exactly true, because some of the areas where they have provided abortion is through the mail is there are abortion clinics in those areas. So their strategy sometimes is a bit inconsistent, but they have really promoted the idea of telemedicine and self-managed abortion. So what does the future hold for chemical abortion? Hard to know, because I don't know that anyone back in 2000 could have predicted in 21 years where we would be today, but definitely less protections for women, less screening. So they definitely want to eliminate the idea of an ultrasound. The ultrasound is so important because it identifies the gestation of the pregnancy. We know that how far along that mom is, and if that drug would be effective at that stage of pregnancy. It identifies if the baby is in the uterus or outside the uterus. If the baby is outside of the uterus, Mephapristone is not effective. So she may have a pregnancy that continues to grow outside of the uterus, an ectopic pregnancy, which would be dangerous for a mom. Also, any screening that might be done for coercion in pregnancy can be done in person. It's much more challenging to do that through telemedicine and through online access. So the idea that women may be forced to start a chemical abortion, which we are hearing more and more through this pandemic time, where women are being forced to start a chemical abortion, either physically or being locked in a room until they agree, things of that nature. The idea of coercion is so important to assess before that abortion has started. And then conscientious objections. We know that in many other countries, no longer can medical professionals object to participating in abortion. And we know that that time may be coming in the United States where it may be more and more challenging for healthcare professionals to stand up and say, this is not something that I want to be a part of. The good news, which I will speak about more in my next presentation, is there is so much hope, and that is because of Abortion Pill Rescue Network and the babies that are born even after moms start a chemical abortion. They have this opportunity to save the lives of their preborn children. And so this is something positive, even though so much of this information I know can be very harsh and hard to hear. There is something really good happening. And in this picture here, this is Dr. Lyle, who is one of our APR medical advisory team members with Baby Journey, who he not only helped through abortion pill reversal, he also was able to deliver little Baby Journey. So there is the possibility that moms can choose again. They can choose abortion and then they can choose life. And so we have that help available, and I am excited to be able to share that with you in my next presentation. APR empowers women with real choices. These are some of my references. This is my contact information. If you would like more information, you can contact us at info@apr.life, or there is my phone number. All right, thank you so much. God bless each of you.